Welcome to Essential Access Health's course on Expedited Partnered Therapy, EPT for short. Today we are going to review what you need to know in order to implement EPT for chlamydia and gonorrhea prevention and treatment. We'll do this by focusing on 4 areas: the basics of chlamydia and gonorrhea infections, partner management for chlamydia and gonorrhea infections, EPT as a partner management option, Essential Access Health's Chlamydia and Gonorrhea EPT distribution program, which offers free chlamydia and gonorrhea medication to eligible clinic sites and local health jurisdictions in California to use for EPT. At the end of this course, we'll provide you with helpful resources for integrating EPT into your clinic site or local health jurisdiction. Let's get started with a brief review of the basics of chlamydia and gonorrhea infections. Chlamydia and gonorrhea are the most common reportable sexually transmitted infections in the United States. In 2019, approximately 1.8 million cases of chlamydia and 610,000 cases of gonorrhea were reported in the United States. These infections are concentrated in young people, particularly females under the age of 25, and in most cases, women show no symptoms at all. Additionally, individuals with an STI are 2 to 5 times more likely than uninfected individuals to acquire an HIV infection following exposure to HIV through sexual contact. Individuals with an STI and living with HIV are also more likely to transmit HIV through sexual contact than an individual living with HIV without another STI. If left untreated, chlamydia and gonorrhea can ascend from the cervix into the uterus and fallopian tubes, causing the more widespread infection called pelvic inflammatory disease, or PID. People with a uterus who have this upper genital tract infection have acute symptoms: lower abdominal pain, irregular bleeding, fever. But PID can occur as a silent problem as well, causing damage without giving any symptoms. The long-term consequences of PID include infertility, ectopic pregnancy, and chronic pelvic pain. An ectopic pregnancy, sometimes called a tubal pregnancy, most often occurs in the fallopian tube, which carries eggs from the ovaries to the uterus and can be life-threatening. Ectopic pregnancy can sometimes occur in the ovary, abdominal cavity, or the lower part of the uterus. We now know that untreated STIs can cause complications. Let's look at ways to manage and screen these infections. According to CDC screening recommendations, sexually active young women under the age of 25 should be screened annually for chlamydia and gonorrhea. Rectal chlamydia and pharyngeal and rectal gonorrhea screening can be considered in females based on reported sexual behaviors and exposure through shared clinical decision between patient and provider. Sexually active women 25 years and older and men who have sex with women should be screened based on risk factors, which include known and suspected exposure, new or multiple partners, possible non-monogamous partners, inconsistent condom use, history of prior STI diagnosis, or high prevalence clinical settings. All pregnant women should be screened for syphilis and HIV at their first prenatal visit, with a retest during their 3rd trimester, and at delivery if at high risk, such as if they live in a community with high syphilis morbidity or high HIV prevalence, or are at risk for syphilis acquisition during pregnancy. Risk for syphilis acquisition could include using drugs, having STIs during pregnancy, or seeing multiple partners that may have an STI or HIV. The Expand Syphilis Screening recommendations, released by the California Department of Public Health in 2020, differ slightly from the CDC recommendations for syphilis and are available on the California Department of Public Health website. For pregnant people, the California Department of Public Health recommends that all pregnant patients should be screened for syphilis at least twice during pregnancy: once at either confirmation of pregnancy or at the first prenatal encounter, ideally during the 1st trimester, and again during the 3rd trimester, ideally between 28 to 32 weeks gestation, regardless of whether such testing was performed or offered during the first 2 trimesters. Patients at increased risk should also be screened for syphilis at delivery. Rapid HIV testing should also be performed at delivery, if not previously screened during pregnancy. For chlamydia and gonorrhea, pregnant people should have a test occur 4 weeks after treatment and retest during the 3rd trimester. Men who have sex with men should be screened annually for syphilis, chlamydia, and gonorrhea at sites of contact, regardless of condom use and HIV status. Consider the benefits of offering more frequent screening for these infections between 3 to 6 months if at increased risk. For transgender and gender-diverse people, screening should be adapted based on anatomy. For example, routine screening in cisgender women under 24 years old should be extended to all transgender men and gender-diverse people with a cervix. If over 25 years, persons with a cervix should be screened if at increased risk. Consider screening at the rectal and pharyngeal site based on reported sexual behaviors and exposure. Frequency of repeat screenings should be based on level of risk. Retesting is important because repeat infection is common. The reason for repeat infection is not usually due to treatment failure. The most common reasons for repeat infection are because the patient had sex with a former sex partner that has an untreated STI, or because the patient had sex with a new partner with an STI. A study of family pact and question diagnostics data shows that reinfection rates among women are 2 to 3 times the baseline positivity rates, and that reinfection rates are high across all age groups. Not only are reinfections common, but they're also dangerous. In fact, complications like pelvic inflammatory disease and ectopic pregnancy become more likely with each repeat infection. Chlamydia and gonorrhea treatment failure is rare. The most common reasons for repeat infection are because the patient had sex with a former sex partner that has an untreated STI, or because the patient had sex with a new partner with an STI. To minimize risk for reinfection, patients also should be instructed to abstain from sexual intercourse until all other sexual partners are adequately treated and any symptoms are resolved. It's also important to note that not all relationships are healthy. Power imbalances that exist between partners that may impact whether or not someone can use protection from STIs. One of the most extreme forms of an unhealthy relationship involves intimate partner violence. 1 in 3 U.S. women report ever experiencing IPV. 1 in 7 men have been the victim of severe physical violence by an intimate partner. Assessing the health of relationships is important at each visit, and it is important to have consistent clinical protocols and culturally responsive referrals if you discover a patient may be in an abusive relationship. We know that reinfection shortly after treatment for chlamydia or gonorrhea is extremely common. These are sexually transmitted infections, which means there is always at least one partner in the picture who also needs management. Let's talk more in detail about partner management and treatment options. Many reinfections are caused from sex with the current partner who did not get treated. As a result, the recommendation is to treat all recent sex partners from the 2 months prior of a positive test. Patients should be provided with a variety of partner notification and treatment options to allow patients to choose the method they think will work best for each of their sex partners. One of the ways to narrow down the list of partner management options to those most appropriate for each sex partner is through patient-provider discussion. Based on the discussion about each sex partner, the provider and patient together can identify the most appropriate options for each partner. The recommended and most effective option is for the patient to bring their partner in with them to the clinic for simultaneous evaluation and treatment. We call this BYOP, Bring Your Own Partner. One of the reasons that this partner treatment method is optimal is because both patient and partner are treated at the same time, reducing the likelihood that the infection will be passed back and forth. Other options include the patient telling their partner directly or anonymous partner notification using an online notification website that the partner may be infected and should go get tested, or the provider or other clinic staff member contacting the patient's partner directly about their possible infection and need for treatment. Some local health departments may have disease intervention specialists that can assist providers in reaching out to partners to notify them of their possible infection and need for treatment. Another partner management option that has been shown to be effective at getting partners treated and reducing reinfection is called expedited partner therapy, or EPT. According to the CDC, expedited partner therapy is defined as the practice of treating sex partners of persons with sexually transmitted infections without an intervening medical evaluation or professional prevention counseling. The CDC recommends the use of EPT by stating that expedited partner therapy should be available to clinicians as an option for partner management. The CDC also acknowledges that healthcare programs differ. Therefore, when and how EPT is implemented will vary from site to site. It's important to regard EPT as one possible option for partner management and recognize that it may not be appropriate for all patients or partners. The CDC maintains a webpage with a map showing the legal status of EPT in the U.S. The states shaded green are those in which EPT is legally permissible. This map is regularly updated as more states pass laws and regulations supporting EPT. One of the most common questions we hear is EPT legal in California? EPT is legal in California. California law has explicitly allowed EPT for chlamydia since 2001, and the law was expanded to allow for EPT for gonorrhea and other STIs in 2007. The current law allows physicians to prescribe, and nurse practitioners, physician assistants, and certified nurse midwives to dispense, furnish, or otherwise provide antibiotic therapy for sex partners of individuals infected with CT and/or GC, even if they have not been able to perform an exam of the patient's partners. This legislation provides an exception to the Medical Practice Act, which states that prescribing, dispensing, or furnishing drugs without a good faith prior examination and medical indication constitutes unprofessional conduct. The new law allows for licensees to lawfully provide EPT and specifies that doing so, because of the exception to the Medical Practice Act, does not constitute unprofessional conduct. On October 4, 2021, the Governor signed SB 306, known as the STD Coverage and Care Act. This bill will require a healthcare provider to include expedited partner therapy, or EPT, on a prescription if the provider does not have the name of a patient's sexual partner, would authorize pharmacists to dispense an expedited partner therapy prescription and label the drug without an individual's name if the prescription includes expedited partner therapy, or EPT. This bill specifies that a healthcare provider is not liable in a medical malpractice action or professional disciplinary action, and that a pharmacist is not liable in a civil, criminal, or administrative action if the healthcare provider's use of expedited partner therapy is in compliance with the law. This will help relieve concerns from healthcare providers and pharmacists in expanding the use of EPT for patients who need it. The best way to reduce medical legal liability risk is to practice evidence-based medicine as outlined by national and state guidelines. EPT is both evidence-based and supported by strong CDC and CDPH guidelines, as well as medical associations. We'll now explore the method of expedited partner therapy. What is EPT? EPT is an alternative partner management strategy, meaning it's intended for sex partners of patients that test positive for an STI, and should only be used if partners are unable to seek care or unlikely to seek care in a clinical setting. EPT is a safety net mechanism for getting partners treated, not a substitute for patients coming into the clinic with their partners to get treated. Every attempt should be made to bring the partners in for testing and treatment. EPT is not a first-line partner management strategy. That being said, EPT is a great, highly effective, safe alternative for partners that aren't likely or unable to get treated in a clinic. More specifically, EPT involves providing the index patient with the appropriate medication or prescription, along with educational materials for the index patient's sex partner or partners. Let's walk through the EPT method. At the index patient's visit, The medical provider will treat the index patient and will also give treatment and educational materials for the index patient to give to their sex partner or partners. Although writing a prescription is an option for EPT, the preferred method is for the provider to give the patient medication for their partner or partners. The index patient will then deliver the medication or prescription to their sex partner or partners along with educational materials. Now, the index patient and sex partners have all received treatment. A number of randomized controlled trials have demonstrated the effectiveness of EPT for reducing chlamydia and gonorrhea reinfection in the index patient. This slide from the California Department of Public Health STD Control Branch shows results from 5 randomized controlled trials. The bars in this graph show the percent of patients who were reinfected at follow-up visit. The purple bar shows the reinfection rate among those who were assigned to patient referral, so the patient was responsible for referring the partner to a clinic for treatment. The orange bar shows reinfection rate among those who were assigned to receive EPT. The first 4 studies that looked at reinfection for chlamydia only, or for both chlamydia and gonorrhea, demonstrate reduced reinfection rates for those receiving EPT. The last 2 studies also had a third category, the green bars, that also worked quite well at reducing reinfection. This group was assigned to patient referral, but also got booklets that had tear-out cards with information about the infection and treatment guidelines to give to their partner. EPT has not shown the same effectiveness in reducing reinfection for trichomoniasis. In addition to being supported by several medical associations, as of February 1, 2020, EPT is a covered benefit for FPACT, and Medi-Cal recipients who test positive for chlamydia, gonorrhea, and trichomoniasis. There are 2 options for providing patients with EPT. The preferred method is giving the medication directly to the patient over providing a prescription, because some prescriptions do not get filled. Providers provide patients written prescriptions for partner treatment and the name of the index patient to get filled at their local pharmacy. Index patients can receive a treatment for up to 5 partners. An essential focus in partner treatment is a discussion between provider and patient to ensure partner treatment. The STI treatment guidelines were released in July 2021 and included modifications for CT and GC. The recommended treatment for chlamydia infections is doxycycline, 100 mg twice a day, for 7 days, and for pregnant patients, the alternative treatment is azithromycin of 1 gram orally in a single dose. Available evidence supports that doxycycline is more effective in treating chlamydia infections of urogenital, rectal, and oropharyngeal sites. Although azithromycin maintains high efficiency for urogenital infection among women, there is a concern regarding the effectiveness of azithromycin for concurrent rectal chlamydia infection, which can occur commonly among women and cannot be predicted by reported sexual activity. In a recent Family Pact course on implementing the 2021 CDC STI treatment guidelines, Dr. Ina Park shared that in observational studies and randomized control trials, the efficiency of doxycycline and azithromycin for urogenital infection was a 3% difference. For rectal chlamydia, there can be an 8 to 20% difference in treatment failure when using azithromycin instead of doxycycline. When non-adherence to doxycycline is a substantial concern, 1 gram of azithromycin is an alternative treatment option, but may require post-treatment evaluation and testing because it has demonstrated lower treatment efficiency among persons with a rectal infection. For patients who are pregnant, clinical experience and published studies indicate that azithromycin is safe and effective during pregnancy. The CDC recommended treatment for gonococcal infections is 500 mg ceftriaxone IM in a single dose. For individuals weighing more than or equal to 300 pounds, a single 1 gram IM dose of ceftriaxone should be administered. If chlamydia infection has not been excluded, doxycycline 100 mg orally twice a day for 7 days is recommended. For EPT, or if ceftriaxone is not available, 800 mg oral dose of cefiximine is an alternative regimen. If chlamydia infection in the patient has not been excluded, the partner may be treated with a single oral 800 mg cefixime dose plus oral doxycycline 100 mg twice daily for 7 days. A TOC is appropriate for pregnant patients with chlamydia 3 to 4 weeks after initial treatment, and any patient with pharyngeal gonorrhea 7 to 14 days after initial treatment. However, because testing at 7 days might result in an increased likelihood of false positive tests, It should be done closer to 14 days when possible. Here are some questions providers might ask their patients to see if EPT is the right partner management option for any of their patients' sex partners. What's the likelihood your partners will come into the clinic? If partners are unlikely or unable to come into the clinic, the provider should check patients' comfort in directly notifying partners about their possible CT/GC infection, providing medication to treat it. If the patient is comfortable in notifying partners, providers should check for whether the partner is pregnant or potentially pregnant so they can receive the appropriate medication. If the answers to those questions are no, then EPT should be considered for use as a partner management option. EPT can be used for all sex partners from the 2 months before diagnosis, or for the most recent partners if the patient hasn't had sex with anyone in the last 2 months. EPT can be used for partners regardless of assigned sex, and the number of doses given will be determined by the number of partners for whom the patient feels they need to use this method. EPT should not be used in certain cases, such as if a patient is co-infected with an STI that is not treatable by EPT, such as HIV or syphilis. EPT also should not be used in cases of child sexual abuse, sexual assault, or if the patient feels it may be unsafe to discuss the treatment with their partner. And, of course, if the partner is known to be allergic to one of the EPT medications, they should not take it. Information about allergies should always be included in the information that is given with the medication. The alternative regimen used for EPT for gonorrhea is not as effective at treating infection in the throat or pharyngeal infection compared to the first-line injectable treatment. If a partner is unable or unlikely to come into the clinic for first-line treatment, EPT can be provided because providing the alternative treatment is better than the possibility of the partner receiving no treatment. So, if EPT is provided for a partner that could have gonorrhea in the throat, they should be informed that EPT medication may not cure throat gonorrhea, and they should consider seeing a medical provider for a test or cure. And finally, if there is suspicion that a more serious condition is indicated, pelvic inflammatory disease, for example, it would also be important to try to get that partner into the clinic. California guidelines cover special considerations about providing EPT to men who have sex with men, or MSM. The guidelines explicitly state that EPT can be used regardless of the patient's gender or orientation. However, there are a few additional considerations when providing EPT for MSM with gonorrhea, including the reduced effectiveness for treating pharyngeal infections. Not bringing the partner in for a medical evaluation also means the partner does not have the opportunity to receive screening for other STIs at the time, such as HIV or syphilis, which see higher rates in this population. Again, the key take-home message here is that while it is always better to have partners come in for their own evaluation, especially for MSM, providers should use shared decisions with their patients and provide EPT in a circumstance where they determine that it is very unlikely to happen. It is very important to always package every dose of EPT medication with written educational materials containing information about the infection, medication instructions, warnings about allergies, drug interactions, or other contraindications to taking EPT medications, instructions for all EPT recipients to seek care for STI and HIV testing. Partners with the cervix should also receive information regarding the signs and symptoms of pelvic inflammatory disease, PID, and what to do if they experience symptoms as the EPT regimen may not be adequate for treatment of PID. Besides patient education materials, take this opportunity to think about how clinic information can be shared. Include clinic referrals and additional information about clinic hours and services. Also consider highlighting sexual and reproductive health programs and resources like PEP plus PrEP, HIV and syphilis testing, emergency contraception, information about health plans like Family Pact for seeking confidential care. There are 3 potential risks of treating a partner with EPT. One risk is having an adverse reaction. The medications used for EPT are generally well tolerated. The most common side effects of taking azithromycin, doxycycline, and/or cefixime are mild and transient gastrointestinal system issues such as diarrhea, loose stools, nausea, and abdominal pain. Another potential risk of EPT is allergic reactions to the medication. Doxycycline is contraindicated for pregnant people. It is very rare to have anaphylaxis or a severe allergic reaction to azithromycin. Allergic reactions to third-generation cephalosporins, including cefixime, are uncommon, even for persons with penicillin allergies. However, cefixime should not be used for persons with a history of an immunoglobulin-mediated penicillin allergy. Despite these potential risks, EPT is very safe. In fact, as of the posting of this course, no adverse reactions have ever been reported in California since the law allowing EPT went into effect in 2001. This risk of allergy and adverse drug reactions may be best mitigated through educational materials that accompany the medication, which, as we previously discussed, should include explicit warnings and instructions for partners with allergies to seek medical advice before taking the medication. Finally, a third potential risk is that EPT might result in missed opportunities to receive other services, as in-clinic treatment has the benefit of providing testing for other STIs and HIV, risk reduction counseling, assessment of allergies, and contraindications to antibiotic treatment, as I just described, and empiric treatment. For these reasons, EPT is recommended only for partners who are unable or unlikely to seek care in a clinical setting. There are a number of EPT counseling messages that are important for both the patient and partners to receive. These messages are outlined for the partners in the educational material accompanying each dose of the medication, but it's also important for providers to discuss these key EPT counseling messages with their patients that are given EPT. When reviewing counseling messages with patients, explain what they are taking medication for. For example, you are only being treated for X. This medication is not a cure-everything pill, but specifically for treating X. This message is particularly important for adolescents. It's important to inform patients that their partner should visit a clinic for a complete STI evaluation to be tested for other infections, including HIV, as soon as possible, regardless of whether they have taken the EPT medication already. Patients should also be counseled to encourage their partners to read the educational material about the infection and the medication very carefully before taking the medication. Partners should not take the EPT medication and should seek care as soon as possible if they are allergic to antibiotics or have any kind of serious health condition, including, but not limited to, kidney, liver, or cardiac disease. Those are the major organ systems that could be affected by EPT medication. Partners who have symptoms of a more serious infection, such as fever, pelvic pain in patients with the uterus, or testicular pain in patients with testes, should also not take the EPT medication and should seek care as soon as possible. Patients should be counseled that their sex partners who are pregnant can use EPT, but those pregnant partners should be strongly encouraged to seek care. A test of cure for chlamydia and gonorrhea 3 weeks after treatment is always needed for pregnant individuals and should be emphasized for pregnant partners receiving EPT. Both patients and their partners should abstain from sex or use a condom for 7 days after taking the medication in order to prevent reinfection, and both should seek clinical services for retesting 3 months after treatment. Essential Access Health's Chlamydia Gonorrhea EPT distribution program supplies chlamydia and gonorrhea medication to eligible clinic sites and local health jurisdictions free of charge. As we discussed, partner management is critical to help protect patients from repeat chlamydia and gonorrhea infections. However, paying for partner medication is often a barrier to getting sex partners STI treatment. Even though treatment of partners is expected to protect the index patient from reinfection, there are insurance plans in California that will not pay for partner treatment unless the partner is also a member of their plan. In response, Essential Access Health started the Patient Delivered Partner Therapy Distribution Program in 2005 to provide free chlamydia treatment to California clinics and LHJs in order to increase clinic access to partner treatment options. In 2012, the program expanded to include cefixime for the treatment of gonorrhea. In order to follow national guidelines, Essential Access Health's Chlamydia Gonorrhea Patient Delivered Partner Therapy Distribution Program is now the CTGC Expedited Partner Therapy Distribution Program. Participating sites are shipped medication that's prepackaged into individual doses, which are dispensed to patients that test positive for chlamydia and/or gonorrhea to give their sex partners for treatment. LHJs may also provide the free medication to chlamydia and/or gonorrhea positive patients and their sex partners through other methods of expedited partner treatment, such as field-delivered treatment. Essential Access requires all sites that participate in the EPT distribution program to bill Medi-Cal and Family Pact for EPT when appropriate and feasible. Clinic sites will demonstrate that they have done so with an attestation on the online ordering platform. Information on the program is located online at essentialaccess.org/PDPT. To participate in Essential Access Health's EPT program, each clinic site and/or local health jurisdiction must meet certain eligibility requirements. It's important to note that if your agency or local health jurisdiction has multiple clinic sites, only those sites that meet all the eligibility requirements may register and participate in the program. To be eligible, each clinic site and/or local health jurisdiction must be located in California, serve a population at risk for STIs and that is uninsured or underinsured, participate in HRSA's 340B drug pricing program, demonstrate inability to purchase and repackage medication, and provide index patient treatment for chlamydia and gonorrhea with no out-of-pocket cost to index patient. On the next slide, we'll dive a little deeper into this last requirement of providing index patient treatment for chlamydia and gonorrhea. To learn more about eligibility requirements, visit essentialaccess.org/PDPT/program-eligibility. If you're interested in participating in the program but are unsure you meet eligibility requirements, you can contact us directly at stdprograms@essentialaccess.org. As mentioned on the last slide, each clinic site or local health jurisdiction must meet the requirement for delivery of index patient CT and GC treatment. There are 3 ways this requirement may be satisfied. One way is to provide direct on-site dispensing of chlamydia and gonorrhea medication to index patients for their own treatment in the clinical setting. In this case, medication from the CT, GC, EPT distribution program can be provided to the index patient by clinic staff. A second way to meet the requirement is to provide chlamydia and gonorrhea medication to index patients for their own treatment through an on-site pharmacy. In this case, medication from the CT, GC, EPT distribution program would be distributed by the pharmacist when filling the index patient's treatment. The third option is only available to local health jurisdiction, and that is to provide medication from the CT, GC, EPT distribution program to index patients and/or their sex partners through field-delivered treatment. Providing index patient treatment is important for participation in the chlamydia gonorrhea EPT distribution program, as it ensures that a chlamydia and/or gonorrhea positive index patient leaves the clinic site with treatment for themselves, in addition to treatment for their sex partners. At clinic sites where index patients receive EPT for their partner but a prescription for their own STI treatment to fill at an off-site pharmacy, it is possible that index patients will instead use the free medication from the CT-GC EPT distribution program for their own STI treatment, rather than pick up their prescription at an off-site pharmacy. This practice reduces the opportunity to treat the sex partners with EPT, therefore negating the intention, effectiveness, and outcomes of the CT-GC EPT distribution program. Furthermore, on-site dispensing improves treatment compliance among STI-positive patients. A data analysis of chlamydia-positive patients enrolled in Family Pact show that 1/3 of patients who received a prescription for chlamydia treatment did not fill their prescription. Non-fill rates were higher among clients aged 18 and younger. Providing medication to patients via directly observed therapy is considered a best practice in STI care. Eligible clinic sites and local health jurisdictions that participate in the chlamydia gonorrhea EPT distribution program must adhere to the following participation requirements. Medication from the program must be distributed to patients who receive a positive chlamydia gonorrhea diagnosis for provision only to their sex partners. A, who they believe are unable or unlikely to seek prompt clinical services, and B, who they believe to be uninsured/underinsured. Local health jurisdictions using the medication for other methods of expedited partner therapy, such as field-delivered treatment, are permitted to provide the medication to the index patient as appropriate. Medication ordered by local health jurisdiction for field-delivered treatment can only be used for field-delivered treatment. Medication may not be shared with other clinic sites. Patient education material and a clinic referral must be provided with each dose dispensed from the program. Patient education materials are provided for free in a few different languages on Essential Access Health's PDPT resources page. Lastly, each participating clinic site or local health jurisdiction must keep a medication log of all dispensed medication doses from the program. Aggregate site-specific data, including data from the medication log, is required to be submitted online with each new CTGC EPT distribution program medication request. Participating clinic sites and local health jurisdictions are encouraged to use Essential Access Health medication log template available on the PDPT resources page, but alternate medication log formats such as integration into electronic health record are acceptable. This is how to order medication from the program. Only the point person may order medication for all participating sites. To do so, the point person must sign into the EPT website and click Request Medication to access the order form. The point person must complete and submit the order form for each registered site requesting medication from the CTGC EPT distribution program. The point person can order EPT medication a maximum of 1 time per month for each registered affiliated site. Although there is no limit to the amount of EPT medication requested per order, Essential Access advises that the point person order a 6-month supply for each site based on estimates from the site's dispensing history or positivity rates. On the next slide, we will review order quantity recommendations for new sites or sites that are unsure what quantities to order. All order size requests will be filled as supply permits. The order form contains required fields to submit site-specific data since the last order from the program. On the order form, the EPT point person must report the number of chlamydia and gonorrhea doses in stock from the program and the number of chlamydia and gonorrhea doses that expired since the last order. Chlamydia and gonorrhea data since the last order must also be provided, broken down by gender, including the overall number of patients that tested positive for chlamydia and/or gonorrhea in the clinic, the number of index patients provided with chlamydia and/or gonorrhea partner treatment from the EPT program, and the total number of doses of chlamydia and/or gonorrhea partner treatment dispensed to positive index patients. Local health jurisdictions ordering medication for field-delivered treatment are not required to submit the number of patients testing positive for chlamydia and/or gonorrhea. Essential Access processes orders placed by clinic sites on the 15th of every month. Clinic sites and local health jurisdictions can expect to receive medication approximately 2 weeks after Essential Access processes the orders. The medication will be shipped directly to each requesting site at the address provided. For questions about the Essential Access Health's Chlamydia Gonorrhea EPT distribution program, please check out the program's homepage at essentialaccess.org/PDPT and the Frequently Asked Questions page at essentialaccess.org/PDPT/FAQ. You can also send us an email at stdprograms@essentialaccess.org. Now that we have talked about Essential Access Health's EPT program, I'd like to introduce you to some great resources for EPT implementation. Family Pact has several billion resources on their website, which include the ICD-10 code and description, procedures, laboratory, supplies, and medications as indicated. The resources page of Essential Access Health's Chlamydia and Gonorrhea EPT distribution program website has many useful EPT materials, including STI screening and STI treatment guidelines and medication log templates. Additionally, there are chlamydia EPT patient education handouts in English, Spanish, Chinese, and Vietnamese, as well as gonorrhea EPT patient education handouts in English and Spanish, available for free to provide with each dose of EPT dispensed. If you're interested in patient awareness materials, such as posters or wallet cards for your clinic waiting room, please email us at stdprograms@essentialaccess.org. A new resource that we have added on our site is our Expedited Partner Therapy FAQs for California pharmacists, which is designed to enhance pharmacists' knowledge, skills, and comfort in providing EPT. We would appreciate sharing this with the pharmacies you work with. For information specific to the use of EPT in California, please visit the website of the California Department of Public Health STD Control Branch at std.ca.gov. There you will find guidelines on best practices for the prevention and early detection of repeat chlamydial and gonococcal infections, and the California EPT guidelines that contains detailed information about the background of EPT, guidance for implementing EPT in your clinic, resources, and examples of EPT partner information materials. Thank you. Please contact STD programs at essentialaccess.org with any questions.